Yeah, good afternoon, everyone. I think all of us, most of us have already joined, and we have our today's moderator, Dr. Ananya, also with us from NITRD. So, Dr. Ananya, I think we can start now. I'm handing over mic to you. Thank you.
Hello, everyone, and I welcome you all to the 56th session of e-NISCHIT TB HIV case series. And I really thank everyone for joining, for sharing your valuable time for joining in such difficult times that we're having. As we all know, digital learning till about few months or a year back, it was just an add-on, but now it has become the backbone of our capacity building and knowledge building. So I really hope through this e-NISCHIT we optimize on that aspect. I will begin by introducing Dr. Vanna. You just heard her, Dr. Vanna from Share India. We have other panel member, Mr. Jeet, Gaurav from ECO, Mr. Jeet from Share, Gaurav from ECO India. They help us in this initial clinics. And of course, we have Dr. Basna, but she's not keeping well. So our NITRD head. So today she might join us a little later. So before I discuss the agenda, can we have the poll for attendance, Dr. Vanna? Can we pull the poll for attendance?
Yeah.
I hope if there are more than 2 people in one room, we are maintaining the social distancing because that is the most pertinent thing in today's time. Carrying on the agenda, today's case is based on a very interesting topics. It is the challenges which are associated in which we face in trying to recognize the response, the right response to the treatment, or identifying the early treatment failure. Because we all know that the 3 parameters in virological, immunological, and clinical parameters, they are not always in synchrony. So what is right and what may not be adequate but can be right in that situation, we would be enlightening ourselves on that aspect, on trying to learn more on how to judge the response to treatment. And for this, we have none other than our expert today, Dr. Alpana Raizada. Ma'am, can you please say hello to everyone? She's the...
Yeah, hello everyone. And
yeah.
I would thank NITRD and the Share Foundation and the entire e-NISCHIT team for having me here for this session today.
Yes, ma'am. Pleasure is all ours. Ma'am is an associate professor, Department of Medicine, University College of Medical Sciences, and Incharge ART Incharge, Guru Teg Bahadur Hospital, New Delhi. Thank you very much, ma'am, for joining us today. So as we know, we have a case-based dialectic. So before the dialectic by ma'am, we will be having a case. So, and the case presentation is would be by Dr. P. Dharampal, Senior Medical Officer, NRI ART Center. So it will, in a short while, after our poll is over, we'll start with the case presentation.
We can have the case now.
Okay. So can I please request Dr. Dharampal to start with the case, sir? Can you please screen share?
Yes, sir. We can see the screen. The case is very much there.
Good afternoon to all of you, the dignitaries on the stage, and my colleagues, friends. I am Dr. Dharampal presenting a case of the extrapulmonary TB of pancreas, which is common, which is uncommon in even the world records. It is only 30 to 80 in the 1 lakh population. But the diagnosis is an enigma in discussing about this case, and most of the times we misled. I bow down at the feet of my teachers who are the oceanic of knowledge, and I learned whatever from them. I am able to diagnose this case with difficulty. But I am once again to give thanks to Dr. Vandana, Madam, who has given the opportunity to present this case. And this case, I'm going to start it. The ART number is A1205, and patient age is 50, and gender is male. Weight is 77 kg. Discordance, the name of the case presented on the discordance between the viral load and clinical assessments of CD4 count. CD4 is not up to 350. The date of registration is 29/8/2016. Date of TB confirmation 10/10/2016. The date of ART initiation is 6/9/2016. Date of ART initiation is 10/10/2016. And the patient history is no previous history of TB. And date of IPT completion is 25/7/2018. And the other details, patient was put on ART on 6/9/2016 with the baseline of CD4 is only 2/9 TL on TL regimen. No history of previous TB treatment. Patient had upper abdominal pain over epigastrium region and admitted in the hospital. ART is stopped due to advice of the physician. Patient is a chronic alcoholic from the last 10 years. He is a supervisor in building construction processes, and patient was treated for pain with antacids and antispasmodics and albendazole. Patient has fever, weight loss, loss of appetite, upper abdominal pain, radiates to the back, and diagnosed as pancreatic abscess. On investigations, further investigations, though ultrasonography, CCT, and pus was aspirated by the radiologist and found to be positive, AB positive, with acid pus bacilli, 4 stain, Jaden stain, grading 4+. Patient was diagnosed as extrapulmonary TB with pancreatic abscess. Patient was kept on ATT and started ART once again on 2/11/2016. After the completion of the ATT, patient was initiated on APT and completed 25/7/2018. The patient has no complaints about his health now. He is free of his symptoms. Actually, before admitting this case, the patient, previously was admitted in various hospitals. Here they are diagnosed only because of his chronic alcoholic history. They thought it is a peptic ulcer or gastritis. And some people, they have given antacids. He used the bulk of antacids much more. But after starting this treatment at the ART center, then only we came to know that the patient has got the pain in a typical way. That is, the pain is radiating back even to the, we thought it is something back because in retroperitoneal structure, as pancreas is the retroperitoneal structure and the pain is going on the left side. So we thought it is more in the culprit is in the back. That means retroperitoneal structures. That is kidney, and we have taken all the investigations and found to be all the remaining things are normal. But the spleen, hepatosplenomegaly is present. And the patient was once again, we have discussed, and with the patient was admitted in the HOD of the hospital. So once again, we had a lot of discussion about this case. And because I have seen 4 or 5 cases previously, so I suggested him, because it is maybe pancreas, maybe the culprit. Then I requested the HOD of the radiodiagnostic structure in hospital, and he promised me that he will help. So we have done that inch by inch, and then we found with an abscess. He himself told, sir, this is correct, pancreatic abscess. Then he aspirated and we sent it for laboratory and found to be a tuberculosis. But the treatment we have given only 6 months, because at the time Dr. Goversop suggested me in some of the discussions, in extrapulmonary TB, the patient nutrition and everything is good. You can put in 6 months and see, then only you can investigate further. And if anything not up to mark, then only can extend. This is the session at the time while I am presenting the case on tuberculosis TB, he suggested. So I followed that one, and we had a lot of discussion. The HOD of the medicine suggested, and the respiratory medicine chief also suggested 6 months is, let us put first of all 6 months and see. Then we found that after giving these treatments starting on 4th day onwards, fever has come down, the patient is in well lab stage. So we have done so many investigations for that. Before that, we have got a special thing, the CD4, and the patient was fever, weight loss, as all the 4 symptomatic signs of the tuberculosis was, as per the guidelines that was present. Patient was kept on ATT and started treatment. And the patient has no symptoms after starting the tuberculosis treatment. And the CD4 count at the time of the ART initiation was the last, we have given 3 serial CD4 counts. First is 229. And afterwards, starting the ART, 189, CD4 second stage, second time is 206, and third time is 289. So these are the 3 things that we have done. And first of all, the viral load we have done. And the first viral load is nearly 39,924. And afterward, starting the ART treatment, it has come down under the TND. And third one is also TND. And the 4th one, after now it is 261. Then we got a doubt, why suddenly it has gone up like that. Then I had a lot of discussion with the patient. He told me, sir, because of these no constructions work and the nutrition has come down mine, so I am not taking up to that one, but he's an alcoholic still. he told me that he's taking only little alcohol because he was unable to do the work until and unless if he can take small amounts. So he told some religious things also. So now we thought it may be nutrition or something. But from the beginning, what I observed is ESR is continuously rising like that. Colon infection, my professor, Dr. Morali, in terms of the nodal officer, HOD, told me that maybe the reason, so it may slowly come down. The alkaline phosphatase and the ADA is also increasing like that. Now it has come down, and we admitted and we are calling the patient repeatedly, and we have taken X-rays and everything, chest X-ray and everything is normal. But only the ADA investigations, ADA is only increased, ESR is increased, serum lipase is 112, alkaline phosphatase is 342. He may question me why serum amylase is not done. We have done serum amylase also, but the serum amylase is only for 24 hours in acute case only, maybe there. Afterwards, it may come down and gives a wrong notion. So my professor also suggested it is better to have a lipase only, because it will at least work for 72 hours. It may be on the levels. So like that. And after taking the TB, these serum creatinine is 0.9 and bilirubin is 0.3, SGOT is 13, and SGPT is 19, and urea is 18, and hemoglobin level is 11.1. At the time of the patient was suddenly, because of using so many drugs outside for these antibiotics and other things, at the time he was 8.8 grams, and we have given some supporting drugs like hematinics and other things. Then only it has gone up to 10.8, and slowly it has gone up. Now is well, it is 10.4. And the smear we have done, and TB positive, and the 25/7/208, and result is positive, and the CB0 is negative. X-ray is chest is normal. Ultrasonography report, what we have submitted is telling bulky pancreatic, heterogeneous eco-texture pancreatic, and seized abdomen, mild hepatosplenomegaly, multiple mild peripherally enhancing nodes at the pancreatic region, periportal region, and lesion. Lymphoid abscess at the pancreatic neck with intraparenchymal extension. And the ECG, we have taken also ECG, thinking that the alkaline phosphatase is also increased. So there may be something wrong, like thinking that one also we have done ECG also, it is quite normal. He has no problem with the heart, and it is also normal. And we have done even the vertebra also we have taken, and because the pain is radiating the vertebral column, and at the level of 2-3 maybe tuberculosis suspecting. So we have done that also, and we found out there is no problem with the vertebra, and that is quite normal. And the ATT we have started with 4 tablets daily as per speak. And now after keeping the patient for so many years together on Jadalan, and viral what the case for us, asked us to put them on the second line, and they registered, and we are putting them the patient on the suggest line and the second line on Jadal 18VR. Second line started on 162018. Still patient have the same regime continuing. Now the CPT we are using, and iron tablets and legume tablets, levocetirizine tablets, remalin, because sometimes because of these antacid may get constipation. So he requested, and so they are prescribed, and Pranta tablets. The CD4, here our thinking is the why it is not correlated with the two things, viral load and CD4. That is an enigma, and we are discussing about that. Because as per NACO guidelines, and one of the bottom line they have given, 5 to 10% may be like that. So they want to see that case also actually. But under these pancreatic, I have to tell thanks to my friend Reddy, CDC, Alam Reddy. He suggested me although the coastal area, the diabetic cases are more. So please estimate how many cases in your OP. It is more than 30% of the cases are diabetic patients. Now it is increasing in our OP also. So we thought it may be diabetic. Why have you questioned me? Why have given albendazole? In Jammu Kashmir, the asterosis is one of the things which is causing the pancreatic obstruction, because there are no gallstones. We have also explored the gallbladder also. So there is no gallstones and like that. So this is maybe the reason may be pancreatic abscess because of tuberculosis. So because of some tuberculosis focus. Here is the tuberculosis is more the patient way surrounding where the more TB patients are there in this area. So maybe one of the reasons we thought like that. But this is the case in nut and shell and short, because this way present now 4 days back also, we have once again seen the patient. Patient is very well and is maintaining well health and is happy. This is in short. And madam, I bring to a kind notice that before that nobody is thinking of that there is pancreas may be involved. But from Ongol, one case has come with pain in the abdomen, and it is found to be pancreatic cyst. Now our physicians are also not running up to about the gastric and peptic ulcer. They are also exploring this one. My teacher, Dr. Nasanagi, was the president of the Surgeons of India, Government of India, once upon a time. He used to teach us, don't run away with the peptic ulcer. There is a Bermuda triangle in our abdomen. That is these behand structures. So examine spleen, pancreas, kidneys, and other things, duodenum. So that was taught to me. And my teacher, my physician, Dr. Shankar Patel, you may know, he is one of the textbook writers in the occupational disease textbook of tuberculosis. He also always used to tell at that time more investigations are not there when I were reading. Now it has become easy because of the more sophisticated investigations we are able to tell. Now at that time he always used to give the importance of the clinical science university. So because of their coaching and their whatever they taught, I have a little amount of knowledge compared to them. So I am able to tell this one and we are diagnosed. Another case, the cyst is from Mongol. So we diagnosed here and we asked the patient to stay here for further investigations. He told, I am not prepared, sir, I am going. So we referred, already we asked him to go to this one Mongol hospital for our center only, for further follow. This is a nutshell matter about the case. Any questions, we are ready to. And I want to tell you, my professor and my nodal officer and HOD of the medicine was in full busy with the COVID. He was in charge complete COVID in our hospital. Our hospital is a COVID hospital, now full of cases. So he asked me to convey. He is unable to come to attend this one. I was very much anxious to attend this class. Actually, he was very interested to attend this class.
Yeah, we understand, sir. Thank you so much. I think now Dr. Ananya might want some questions, maybe if participants have, for Dr. Dharampal.
Dr. Dharampal, would you be kind enough to repeat? The audio was not very clear. Why second line was started in this patient? What discussions were then? Why you started second line? Why and when? What was the state of the patient then? Would you be kind enough to repeat that? Because audio was not very clear at that time when you were saying. Second line. Why was second line started on this?
Yes. Second line started because of the high viral load in the beginning. And they thought we referred that case as per guidelines. And they thought it is necessary to put them on the second line. And this asset itself, they discussed it and they put it on the second, not myself. There they advised us to give. Giving that one only because of second line, the serum bilirubin level is because of PLHIV, its action is high, but now it has come down and the patient is happy. He has no some signs and symptoms. But the only thing is, even though we are giving a lot of these multivitamins and other things, supporting drugs, but still CD4 levels are not reaching up to mark. That's why. What is the discrepancy in the reason between that? Anything can we miss? Or can you tell me? I am happy. What to do? Or otherwise, if you say it is slowly increasing, means I will have to wait.
Okay. Okay, sir, I understand. Okay. So before we enlighten ourselves with the expert diabetic, can we have the pre-poll test? And meanwhile, I'll try to summarize the case. Though sir has all these cases worked up and the center excellently worked up and they're always well presented. So I don't need to, but still. So we have this case of a 50-year-old chronic alcoholic who had never received ATT, and he came with a very low CD4 of 29. He was started on ART, but later, subsequently, he had developed upper abdominal pain, for which he was thoroughly investigated and evaluated. and with ultrasound, CT, and pus aspirated, and he was AFB positive, and so he was diagnosed as a case of extrapulmonary TB with pancreatic abscess. Patient was kept on ATT and started on ART again on 2nd 11/2016. So this and plus all the other investigation which we just went through, Dr. Dharpal made us go through, so we all are apprised of that. So our main discussion on this point is that, as I said, that what to expect. We expect that if the patient viral load is coming down, CD4 to go up, or clinically, we try to correlate all the three together. But so apparently in this case, there was CD4 never came up to 350. So there was some kind of discordance that as a physician, people felt that there's some discordance between the three parameters. So for this is the case. This is the reason why we have got this case presented, and our diabetic is going to clear doubts on that. So let's have the diabetic in few minutes. Let's first do the pre-poll test, all of us. I hope everybody is marking the answers. It's anonymous. Just just mark what you think is right. They're very good questions. Dr. Vanna, do you think we can start with the diabetic? Is the pre-poll test over with?
I think we can give 30 seconds more. We have large audience and only 44% has attempted yet. So we request everyone to please attempt. These are only 2 questions, interesting ones. Okay, Dr. Ananya, we are ending the poll. So maybe you can proceed now. Okay.
Would like to request our expert, Dr. Alpana ma'am, to please kindly start the diabetic.
Thank you, Dr. Dharpal, for this excellent case and a very well worked up case indeed. And a pancreatic abscess presenting very early in the course of the patient presenting with HIV to an ART center is indeed very rare. And isolated pancreatic abscesses, as far as literature says, is like to the tune of less than 0.5%. And the case was well managed, identified in time. Otherwise, it can carry a mortality of up to somewhere around 10.5, 10.8% is the usual mortality seen with cases of pancreatic abscess. I would like to begin with a little case summary, though that was already a little summarized by Dr. Ananya Prabhu. So we have a 50-year-old male, probably was 46-year-old at the time when he presented to the ART center. I'm not very sure whether this is his age as of now or previously. Was a chronic alcoholic, was consuming alcohol for the last 10 years, a construction worker, and had no previous history of TB treatment. He came to the center on 26th or 28th of August and was initiated on TLE on 6th of September 2016 with a baseline CD4 of 29. The patient in a couple of days had pain over epigastrium and was hospitalized. ART at that point of time was stopped by the physician. The patient was treated for pain with antacids, antispasmodics, and albendazole. Patient thereafter had fever, weight loss, loss of appetite, upper abdominal pain classically radiating to the back, was diagnosed as extrapulmonary TB. The pus showed 4+ AFP positive on ZN stain, and the patient also had a pancreatic abscess along with lymph node involvement. Patient was kept on ATT, and the ART which had been stopped was thereafter restarted on 2nd of November 2016. After completing the course in 2017, the patient in 2018 from February to July was initiated on IPT, and IPT was finished on 25th July 2018. Currently, as per sir, the patient has no complaints about his health, has been doing fine, and whatever records have been provided, he is gaining weight and is clinically doing fine. So Dr. Dharpal, if all is okay, do you concur with whatever I have summarized in the case? Or there is something which you would like to add as of now also? It seems it's fine with him. I've made a little treatment timeline just to show what happened where and the kind of, lacuna which I find in the history which was provided. So got registered in ART on 29/8/2016. ART was initiated on 6/9 with a CD4 of 29. TB was confirmed. ATT started on 10/10. By that time, ART was withheld. TLE was restarted on 2nd of November 2016. ATT was continued till June 2017, and IPT was from February to July of 2018. So this is what we were provided with, right? Now, my questions were like a patient who came to the clinic with a CD4 of 29 is a fairly advanced HIV, but there is no mention of any symptoms or signs of HIV, advanced HIV in this patient at that point of time. So going by what has been given, we assume that he was very much asymptomatic at the time of being registered for ART, as well as at the time when ART was initiated, which is roughly around 7 to 8 days. So the center was very prompt in initiating ART, which is right. Now, I'm not sure as things were really examined, but a patient with CD4 of 29 not having any symptoms or signs of advanced HIV is a little difficult to comprehend. Then exactly, it's not mentioned as to how many days of starting ART did he develop this epigastric pain for the very first time. And at that point of time, the physician had stopped ART, but what was the duration of stopping this ART is again not known. Was ART thereafter withheld and restarted only on 2nd of November, or it was started in between after this pain subsided? Then the duration of fever, weight loss, loss of appetite, these are again not mentioned. And since the difference between initiation of ART and the initiation of ATT is barely somewhere like 3 weeks, and I'm not even sure whether the patient was intermittently on ART by then or not, or had he only consumed ART for maybe 6, 7, 8 days by the time he developed epigastric pain, this is not really clear. And whenever we mention that the patient has history of weight loss, was weight loss not there when the patient presented on 6th of, when the patient was initiated on ART on 6th of September? These are the questions which all centers have to really take care of, because if you expect that weight loss had occurred after initiation of ART and was so substantial that the patient could really make out that he had weight loss in those maybe 18-20 days of starting of ART, this is basically a little lack of history taking probably at that point of time. So these were the 3 questions which appeared to me very relevant over here. Was he not really looked upon as a case of advanced HIV when he came to us? The duration of stopping ART, or practically I'm not even sure, from 6th of September to 2nd of November, what were the number of days that he actually took ART? And then thereafter, the duration of fever and weight loss. So to assume that everything started after ART initiation and very close back on heels of ART initiation, that is how the case appears to be currently. So whenever a patient develops any infection while being on ART, this means it is an OI which has occurred in a patient on ART. Now, an OI which occurs in a patient on ART, you can have it occurring within 12 weeks, within a couple of weeks, or beyond 6 months of starting ART. That is how we normally differentiate between what could the cause be. Since we do not have a corroborating CD4 at that point of time done when ATT was started or the patient was diagnosed with tuberculosis, we do not have another CD4 done at that point of time. So it is very difficult to say whether this was a case of suspected iris or whether this was an infection or an active OI which had been missed previously, and now it had just become a little more overt in due course of time. Had it been beyond 6 months of starting ART with a fall in CD4, we could have suspected a treatment failure at that point of time. But this happened right within 20-21 days of starting ART, and that too with a treatment interruption in between. So this is not clear. Now, how do you say whether it is not iris or is this iris even on clinical basis? So we know that 10% of all patients initiated on ART can at some point of time develop iris. And up to 25%, this 10% goes on to 25% in those initiated on ART with a CD4 count of less than 50. So our patient was right there with a CD4 count of only 29. So he developing iris was a strong chance. Typically can occur within 2 to 12 weeks. So if we look at it from that angle, our patient had been on ART for 3 weeks before he developed this complication of pain in epigastrium radiating to the back. Do we call it, if we take it, assume this to be iris, do we call it a paradoxical iris or an unmasking iris? So yes, it would really fit into an unmasking because the patient already was not on tubercular treatment. So it could have happened that a new active TB was unmasked while the patient was on ART. But as I said, since we do not have a CD4, we cannot really make a confirmed diagnosis of iris in this case. Another pointer which is in favor of that it could have been an iris, if you look at this point number 1 and point number 4. So any unexpected localized disease, either in the form of new lymph nodes, which are enlarged, suppurated, or involvement of intra-abdominal organs like liver or spleen, in this case, the pancreas also, or an atypical inflammatory response in tissues. This was an atypical response. We do not expect suppurative lymph node disease right after starting ART. So this was an atypical inflammatory response, which could have occurred in the form of granuloma, suppuration, necrosis, any of it. So in our case, this was a lymph node, peripancreatic lymph nodes which had suppurated, and this had thereafter extended into the body of the pancreas and had presented as a pancreatitic abscess with pancreatitis. So the diagnosis, it is mandatory that a CD4 cell count should show a sudden rise, which is not there with us. So by and large, we do not even know whether CD4 fell down during that point of time. We do not have that CD4 also. So all in all, probably it was an active OI which might have been missed right at the onset and could have been picked, but thereafter also I would still say that hats off that you picked it up in time, because had you picked it up even later, your patient could have landed up in frank peritonitis, and this would have added basically not just to his morbidity, but could have cost him his life. So because of this, we are not going ahead with a diagnosis of iris at this point of time, but to me, it appears like it was an active OI which we had somehow failed to recognize. As Dr. Dharampal had pointed out, the one thing which I find really worth mentioning here is that right at the onset, there was an ESR of 100, which you had with you at the time of initiating, even prior to initiating ART. So on 1st of September, you had an ESR which was 100 when the hemoglobin was 11.1. So hemoglobin was not really contributing to this rise in ESR. So this kind of picture, whenever you have, though you have done really well, you had a normal chest X-ray, which is normally what's the first thing which we try and rule out is a pulmonary tuberculosis in any such patient. So you had an ESR of 100, which was worth taking a little note of. So whenever you have a patient who presents to you for the very first time, is a patient with advanced HIV with very low CD4 counts, and this ESR, this is not just another routine investigation. This is a sensitive indicator that we need to look out for certain other infections which might have been missed by us, and we can take a little more time in initiating the ART than normally what we take.
Actually,
Thereafter, yeah.
Actually, this case was referred to by a physician to us, madam.
Yes.
Actually, he was speaking by a physician outside practitioners also. Even in the gastroenterologist also seeing the case. They thought they have given antacids, and while he was very weak, they used to give some saline and other things and some drugs, antibiotics also used. But suddenly, after doing some investigation, they found the patient is positive. Then only they referred the case to us, and then we have seen this one. What you are telling the iris, after starting the drug, that's also. We put and vigilance on that, also taking that one. And routinely what we do is, even the patient one day off or whatever it may be, we will refer the case for tuberculosis testing also. Extra visiting routinely we are taking. So hepatitis B and hepatitis C and all other things are being investigated are done regularly. So actually we found all things are normal. The problem is only he's an alcoholic, like that. Suddenly one night he admitted in the hospital. So they asked him not to take any food because of this. He is telling, whatever I am taking little amount food, I am getting more burning sensation and vomiting sensation. So they have started IV fluids and they kept him in the hospital and bland diet and like that. So what he is a non-vegetarian, regular taking fellow. So he told me that, sir, I am getting weak because of he was become weak. Just I went to water and I seen a gentleman. And I asked him, whether you are getting this. Sir, I am eating a daily good food, but now because of the pain, I am not taking anything. So at the time, the apoptosis is present and the GOT also raised. The physician advised me because of the chronic alcoholic hepatitis wave also present. let us say, not to continue the same drug, just like hepatitis once again. So they HOD at that time, he stopped the drugs. He asked me to stop this temporary time. First of all, the tuberculosis expert also told me, first let us cure the tuberculosis. Let us start our TB drugs. Then only your game will start. So he told me jokingly like that. So we stopped that time and we started the anti-tubercular drugs. And that is the time, because we cannot tolerate all these drugs at a time. So what in my personal observation also, previously we gave you to say start immediately and same day like that. So sometimes the patients are getting vomiting because these our patients are not like European patients who tolerate all these things at the time because of the lack of food and our Indian patients are there. So we are running the patient because the global death itself causes some vomiting symptoms. If we give the same drugs once again, they are run away from the treatment also. So we are giving first anticoagulation treatment and wait after making them continuously counseling for 2 weeks like that, and afterwards we use to start. So there is no problem to us. That is the thing going on. That's the difference in what they relieved them after keeping like that. Because here in our hospital, all the patients are free of cost, even in everything, even because of our ART patients. They have given that advantage to us.
Yeah, thank you, Dr. Dharamwal. I do understand that whatever was done was well consulted, and I'm not really putting it up as a complaint or something. I'm just saying that whenever, because we have more experience with such patients, so whenever we have such kinds of investigations, we can still take a little more time, and if we have a normal chest X-ray with no such complaints, we can still go ahead and elaborate more history and perform a better clinical examination to rule out extrapulmonary forms of TB as well, especially when you have a patient who's presenting as late in the disease course. So preparing this, why I'm saying so is that because we are all hard pressed, I know there is a lot of analysis which goes on as to when the patient was registered and when did the ART start, and a lot of explanation is sought as to why the patient was started late or why we lost a patient who was registered but could not be initiated on ART. So not just you, all across the country, all of us face the same issues that we want to start our ART as early as possible. And when a patient presents with a CD4 somewhere like 29, it really puts us into a fix, because what we want to do is put him to ART to give him that advantage of ART at least now, despite he presenting as late. But since ART is a lifelong issue, we need to take care that all these 4 parameters, or these 4 prongs of putting up a patient on ART or preparing a patient on ART, right from clinical evaluation, lab evaluation, treatment of OIs or psychosocial counseling, they are all equally important. And your patient was a chronic alcoholic too. So for any patient who has any substance abuse or even otherwise, these healthy living practices and repeated counseling about them also form a very major role. So treatment of pre-existing OIs and CPT initiation. CPT, of course, was initiated, and probably a little lack of, maybe what I can say is all of us do that, not one center. Now, nothing is center specific over here. So when it comes to really performing a good physical examination or a very elaborate history taking, there at times we are at a little loss. This is what we have to really focus on, because a very good history taking can do almost all your job. You're not even supposed to examine a patient too closely. Your history is going to guide you as to what to do for your clinical evaluation. The second thing which is very important over here is the 4 symptom complex. As I had pointed out earlier, the patient developed fever, weight loss very close on heels of starting ART. So this 4 symptom complex is not just another activity to be done. This is a very sensitive tool. And by and large, all of us through every session or wherever the teaching learning program has been going on, this 4 symptom complex is something which practically every person sitting in the ART clinic can keep on asking repeatedly. So this is a very sensitive tool with a sensitivity of more than around like 80-85% sensitivity, though the specificity is low. But what we are concerned is about the sensitivity of the symptom complex. And even if the patient has one of it, you need to investigate the patient further. And this is not just for pulmonary tuberculosis. It is going to give you an idea about extrapulmonary forms of tuberculosis also. So if there was weight loss within 2 weeks of starting ART, then I assume there was probably weight loss or fever or maybe pain in abdomen at the time of initiating ART also. So this also has to be taken in mind, that this 4 symptom complex for TB screening among PLHIV has to be taken up very seriously by the person who comes in first contact, by the counselors, by the medical officers also. So ART, I want to make it a point that ART is not an emergency intervention. Wherever you feel that you need to take a little more time before contemplating on starting ART, that time should be taken. If you feel your patient is not well prepared for initiating ART, there is very much reason that we can hold back ART for a little more time, only as much as is justified. So let us not take it as 29 ka CD4 lekar aaya. So this is something which we need to do very early, though on 1st of September, you had documented most of your investigations as, good enough to start the patient on ART. So these are your serial CD4s and VLs. Ananya had already pointed out that what was the reason for putting your patient on a second line. So this is just a little timeline again in terms of the serial CD4s and viral loads. So ART was initiated on 6th of September. So because we are not doing a baseline viral load through the program, so obviously it was not done. At that point of time, CD4 was 29. Then ATT was initiated somewhere here on 10th of October. By then the ART had already been withheld. Thereafter, ART was restarted on in November. Then the next CD4 which we have is in month of April, which is somewhere almost like 6 months from ART initiation, right? So which was 95. So it wasn't as if the CD4 had fallen below the baseline. It had actually increased by a substantial number. In between, we diagnosed TB. The patient was put on ATT and ATT was completed in June 2017. However, the CD4 which came out in January 2018 was 51. So you were obviously expecting a higher rise in CD4, and this 51 was lower than the 95 which was recorded previously. Then a VL was done. From November, the patient was like roughly 5 to 6 months of ART, and a VL was done thereafter. And this viral load was pretty high, somewhere close to 40,000. So with one single VL and a CD4 count, which was, not exactly half of the peak, and definitely not lower than the baseline, which are the immunological criteria, but yes, did not touch 100 within first 6 months. The third criteria, immunological criteria, was there. But with a single VL, probably you went in for a SASAP referral, and they thought it was essential that the patient be switched to a second line. And so we had a second line in the form of ZL-ATVR, which was initiated on this patient. Close on heels, within 2 months, we again repeated a VL, very close on heels. Within 2 months, we did a VL again. And corroborating quite close, the dates are pretty close to each other. So a CD4 at that point of time was 108, and a VL of 29 on 29th of May was target not detected. So this was roughly a month from switching the ART. So if we see in terms of a switch of ART, the patient was on a newer ART, a newer second line treatment for 1 month, and thereafter a viral load of target not detected was seen. So this can fairly happen. By 3 weeks, you can have a TND also documented if an efficacious regimen is being used. The CD4s thereafter were like 123, 189, 206, 261. At no point of time did the CD4 fall, but the issue which the center has raised is that it has not over time touched anywhere close to our 350 mark, or maybe as we, in some studies, they would say that for a patient to behave like an HIV negative individual, he or she should be touching the 500 mark to behave like exactly like an HIV negative individual. So this is how it happened, somewhere on a single VL. But yes, if the patient's clinical condition is very bad, even a single high VL can be good enough to get a SASAP referral. And then it is the prerogative of SASAP whether they wish to change the ART regimen on a single VL, which is very high. We have no documentation of a step-up adherence at any point of time. Probably the patient was not good enough clinically, and so an urgent SASAP referral was asked for, and somehow they decided that the patient was to be taken up on a different regimen. So the clinical status, as you can see from this slide, it is the last to appear. And why we use the viral load as a marker for changing or switching our regimen is because this is the first to start rising. It is the most sensitive indicator, and there are only small blips in viral load, so that those blips are accounted for when we take our level of cutoff as somewhere around 1000. CD4, you already know, has a lot of variability in terms of any recent viral infections, immunizations, pregnancy, diurnal variation. So CD4 is not something which nowadays we use for switching our regimens, right? So it is invariably, and now since viral load is available to all switches have to be viral load based. Any treatment failure, if you document, has to be viral load based. So clinical status, of course, comes at a very, very, very long time later. By then you have lost half the battle. So this is just to show why we need to document our viral loads well in time, which is like 6 months after starting an ART treatment regimen, and then 12 months, and thereafter every 12 months if the patient is doing well. So these are the criteria, nothing new. All of you are aware of these, but ideally what is now advocated are 3 sessions of step-up adherence, and adherence in each of the last 3 months has to be more than 95%. Now the coming slides, which now are basically what you had submitted for this case, I am, please do not take it, there's nothing personal about it. My center, your center, every center across the country, we are into this kind of documentation. So we see the regimen given, and every time you have those remaining pills which are mentioned, and then we have our adherence, which is documented as 100% throughout. And this is what we actually even feed thereafter. So now with the new system, they do it directly by the date of dispensation, but prior to that, it was we who were providing what kind of adherence our entire population is showing. So this is a little, not up to mark as why we are having 100% adherence, and yet the pill counts, the pills remaining with the patient are always there. And we somehow see that the patient always came in time. The date of visits, he always maintained his date of visit, which is very nice, because he was very particular in coming to the center right on the date at which he was called. So again, over here, what I would like to make note is that I hope everyone knows how to do a good adherence calculation, because now your patient is on ZL-ATVR. We have 2 different drugs. One is given BD, another one is given OD. We need to calculate adherence separately for both of them, and adherence which is coming shorter in the 2 calculations is then taken to be the adherence for that particular regimen. So ATVR के लिए अलग से calculate किया जाएगा, ZL के लिए अलग से calculate किया जाएगा, and whatever comes to be the lower figure, that is now taken to be the adherence. And it's very important how to take it, when to take it. All these things are also important when we say that we are going ahead with a very efficacious regimen. So this is again what I want to say, 100% adherence is very, 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 very difficult to achieve. And if you're achieving it, that's pretty good. But with the kind of pills which the patient has, remaining number of pills, this probably seems to be not rightly documented or computed. So this we can take care of. Adherence is something which is very essential. Coming to the point, the discordance, and this is a very pertinent issue, and why CD4 is not up to 350. So at the onset, let me tell you, there is no sacrosanct figure as to what number of CD4 should we achieve in what amount of time. We do expect it to rise. So this is a wonderful article. If any one of you happens to be more interested in reading through it, the course of untreated HIV infection and what happens after the patient gets initiated to antiretroviral therapy. So this is basically figure A, which is untreated infection, the natural course of HIV, if you are not giving a patient any intervention in the form of ART. So as you see, when the patient is in acute seroconversion syndrome, there is a very rise in HIV RNA, and there is a steep fall in CD4. Thereafter, HIV RNA assumes a plateau to somewhere at a midway peak, and the CD4 keeps on falling. Once the CD4 has fallen to a certain limit, the viral load again starts rising, and at this point of time, the patient starts showing some manifestation of HIV/AIDS. As you can see in the other figure, this is known to all of you. This is probably not known to every one of you, so you can just have a little better look at it. As you can see, the patient, there are 3 patients who have been put on ART. There is 1 patient who was put on ART when he was somewhere around maybe 250 CD4. And you can see the slope and the rise You know, just don't see whether it crosses 500. It does cross 500 at somewhere around 6 to 7 years of treatment. But the slope is also pretty good. The slope has been achieved by 3 to 6 weeks of starting ART. Whereas the one who had started ART at a very lower CD4 count, like our patient started ART at a CD4 count of just 29. So if your patient starts, so our patient must be somewhere over here, if you can see the laser pointer. So in this, the patient probably started CD4 at somewhere around 100. If you compare the slope of starting at a CD4 of 100, of starting CD4 at maybe 200, or starting CD4 at 250, 300, you can see that those who start at a higher CD4, they achieve this normalcy much earlier, at a lesser number of weeks, and they even attain their higher CD4s, close to normal CD4s, in due course of time. Whereas those who start at lower CD4s, like in our patient at a CD4 of 29, so I would expect if I plot a graph for this patient, it would come somewhere like this. So our patient, even after they have shown in this graph up till 11 years, so you can see majority would not be achieving this normal CD4 even after 10 to 11 years of treatment. So this is something which we have to live with, that even after so many years with the viral load being completely suppressed, we may not be able to achieve that immunological golden figure, right? So, but why does it happen? Couple of them are basically all research oriented issues, but as you can see, older age, our patient was probably somewhere between 46 to 50 years of age at the time of starting ART. Low CD4 nadir, a very low CD4 count in our patient, just of 29. High baseline HIV RNA, we are not aware of because we do not do a baseline HIV RNA for our patients. Other things like HLA typing or genetic polymorphisms, these are basically more research oriented, but yes, I've just put them on the slide to say that there'll be many more factors which we cannot really account for. Low thymic output, wonderful gland thymus, which we have all forgotten as to if it has to do anything with HIV in adults. But yes, smaller thymus has been correlated with poor CD4 responses. Poor marrow function, increased immune activation is something which is very essential and which is probably a big reason for this case, this patient not mounting sufficient CD4 counts. Viral factors, please be close on heels. We've already done our HBV HCV screening for your patient. Other viruses may also affect poor CD4 T cell recovery. So these are immune activation. Another slide, don't get flustered. Ke ye kya lekar aaye hain. I'm just showing that the purple line on the top is immune activation. Whenever a patient has HIV, even if he is virally suppressed, there is some amount of viral replication which keeps on continuing slowly in reservoir sites. And this immune activation, despite being on ART for so much of duration, this is 11 years, this immune activation, this purple line does not come to normal. So this is something which will keep on happening. And with more number of infections, treatment interruptions, poor adherence, this immune activation line would still be higher up if we do not take care of those factors. So what happens? Why this residual immune activation despite ART? So as I said, there are tissue sites like lymph nodes and GI tract which will have persistent HIV replication. All these viral proteins, inflammatory lipids will keep on activating immune system. The co-infections like TB, HIV, HBV, HCV, CMV, they have all been linked to increased activation. And if someone is keen on doing research, maybe they can go ahead with lipopolysaccharidases or CD8 cell activation techniques also. And there is microbial translocation also, which is a very major factor. What happens is because of HIV, the gut loses its normal mucosa. The microbes from the bowel, the bacteria from the bowel, they enter through that breach in integrity of the mucosa. And once they are inside, they cause a lot of immune dysfunction within the GI tract. And then there is a lot of collagen deposition and fibrosis. So the entire architecture of the lymph nodes of the GI mucosa over time gets disrupted, and we no longer have CD4 cells production actually occurring from those sites. So this is just a vicious cycle which keeps on happening. Immune activation causing translocation, which leading to collagen deposition, which leading to fibrosis, which again leading to suboptimal CD4 recovery. With suboptimal CD4 recovery, if on top of it you do not have a virally suppressed patient, you may have even more of immune activation. So this can keep on going. In this patient with HIV-TB co-infection, there is excessive T-cell destruction, which happens even after virological suppression, as in our case. We have been having 2 target not detected, and the other one is also fairly good, 261, which might just have been a blip. So HIV-TB co-infection has even more higher levels of activation markers than innumerable studies now. A lot of people are taking a lot of interest in this area, and this case is a wonderful example of putting up this research question. And there is a slow, as I said, that the slope of increase is also slow. So there's a slower rate of CD4 cell increase during early period as compared to patients who are simply HIV mono-infected. Jinme TB nahi hoga, you will have a more rapid increase of CD4 and a more sustained increase of CD4, and they're more likely to achieve those CD4 levels which you want to see in your patient. So these are basically a little theory. These are called immunological non-responders or non-immunological responders, so INRs or NIRs. So up to 20% of patients can have this discordance, that the target not detected values with CD4s which are not really matching. You may even have patients who are falling CD4s also. We have a lot of difficulty because we are mentally very stressed out that we are missing out on some OI and we are not really getting what that OI is. So this is a variable CD4 recovery which happens. And the only point which now I want to make out of this slide is that these patients have to be taken care of much more than other patients of yours who are showing good immunological recovery, good CD4 counts, because these are the patients who are at risk of both AIDS related as well as non-AIDS related events. So they are more predisposed to liver disease, cardiovascular disease, as well as to cancers. So they have to be more closely followed, more better counseled. Their adherence has to be checked much better. Their simple infections have to be taken care of much better than any of your other patients. So of course, that's a dictum that people who delay their therapy till CD4 has fallen to 200 are at a big loss because they may not be able to achieve those kind of CD4s, which puts them at lesser risk of both AIDS as well as non-AIDS related events, is pretty high in such patients. So the take-home message from all this is that, of course, ART should be initiated as early as possible, but only after we have done a thorough preparedness counseling. We have ensured adherence and retention in care also. Good history taking, good clinical examination to rule out an OI. It is not an emergency. In certain cases, we might take a little more time. Maybe if you had thought, "Ke zaruri lagta," then we could have gone ahead with a USG also. Adherence recording should not be taken lightly by any of the centers. That's very important in all cases on ART. Treatment interruptions as far as possible should be avoided. Positive prevention should be definitely a part of counseling because this can have a good bearing. Your patient is still consuming though a smaller amount of alcohol if possible, if he can be motivated enough. I know it's not something, it is easier said than done, but that has to be taken care of. And somehow in your presentation, I found that pantoprazole is still part of your regimen. I hope you have taken care as to how you are giving it with ATVR, because PPIs and antacids, when you are giving with ATVR, you have to take a lot of caution of the timing which you do. So I hope that he's not taking it all together, Pantop, ATVR all together, he's not taking, because then over time, we may land up losing this important second line treatment also. And treatment failure and switch of regimen, they should all be based on viral load, which should be done after ensuring step-up counseling, ensuring good adherence of more than 95% in previous 3 months. And the last thing which we fairly do not really take too much note of, so aap jo clinical status aap dekhte, right, in terms of your weight gain and other things, blood pressure monitoring, lipids, sugar, all of these things should also be taken care of promptly. So thank you so much. I'll get back to you when again asked for. Thank you, Anand.
Thank you, ma'am. Thank you so much, ma'am. Thank you for the excellent presentation. You made a lot of concepts very clear to us, which are otherwise very confusing. And now we know that we have to be very clear in our basics also, like in history taking, adherence monitoring, And we also enlightened on the concept of immunological non-responders, because that's one thing which really confused. Even when the case is worked up, the CD4 counts are something which really confused all the physicians at ART center. So thank you very much, ma'am. So because we are running out of time, I'll quickly have to ask Dr. Vanna to put the post-test poll. Dr. Vanna, and if anybody has any question, please you can ask the expert. You can take that advantage. Any confusion, Dr. Dharampal? And were your concept clear now? Are your confusion clear? Is there anything you still want to ask, ma'am?
If you're running short of time, Ananya, you can please share the email ID. So if even after the session they have any query, they can put it up, or you can forward it to me. I'll be happy to answer.
That's excellent, ma'am. Thank you so much. We'll do that. Please attempt the post-test poll. I think the answers will be clear now. Vanna, as we are running short of time, can we discuss the post-test poll answers as they do it? Because we are running short of time. Yeah. Can you please
so
discuss
we have
the answers?
2 questions here. So the first question says that please select the correct option for the treatment recovery of CD4 T cells on ART is variable. So now after a wonderful presentation, we know that yes, it is true. Recovery of CD4 T cells on ART is variable. So the answer is the first one. And second question is that is asking for the factors which is associated with poor CD4 T cell recovery. And we have here 3 factors: immunological, viral, and host factors. And one option is all of above, and the other is none of above. So now we know that all the above factors are responsible and can be associated with a poor CD4 T cell recovery. So that's all. And as Madam has already said that yes, we can take questions even after the session. So we know all the participants can write at e-NISCHIT@gmail.com. Any query you have related to the case or otherwise can be sent at this email.
So I think we can close the session now and say thanks to everybody. Thank you, ma'am. Thank you, Dr. Vanna. And thank you all of us for joining in, who all joined. We'll just end it with a feedback poll.
Yes, thank you everyone. We are signing out. Thank you, Dr. Dharampal. Thank you, ma'am. Thank you, Dr. Alpana. Thank you, Dr. Ananya. Good afternoon, everyone. Have a great day. Thank you.